Speaker is Mr. Jomo from Patras. We hear about medial and anteromedial aspect.
So, thank you a lot for the kind invitation. I will do my speech in English just to be polite with some international speakers. One and a half months ago, I was invited by our president to speak about the medial and anteromedial aspect of the knee. And honestly, I was thrilled actually. It's an anatomical area from my perception, my point of view, that's very crucial. And given the fact that all publications are heading to the anterolateral part of the knee, my way of thinking is that this is actually the most important part. And actually, as I will say to you, it's actually the cause of the anterolateral is the result. So back to anatomy, as we all know, and I studied and I read this last month that Kouloumentas and associates published this nice publication about the really crucial part of our posterior medial part of the knee. The ramp lesions is really crucial, and we should always consider this. Why are we here speaking about the revision ACL? Because we have like a 10% percentage of rupture and re-rupture rate, and something obviously is missing. So Kebler and Associates published the evaluation of failed ACL reconstruction, and they told us that there are some major failure causes: the high tibial slope, unaddressed high-grade pivot shift, unaddressed concomitant injuries, and some technical errors, especially the femoral tunnel. The ACL consensus also published this. This is a patient of mine actually from today. The tibial slope is 14, the middle part, and the lateral tibial slope is 15, the way I measure it, as you can see. And it's really crucial to always say that it's medial or the lateral part. Did we fix the ACL? How it's ruptured again, I mean, but did we ignore the knee? So we always have to think the whole as the knee as a whole joint, as a system. We have better grafts these days. We have better fixation. We have better tunnels. We have better implants. But still, we have residual pivot shift. We have rotational instability. We have some 10 or 15% of failed ACL, which leads us to early cartilage degeneration. So, thinking back to the history of ACL, we can remember the 1990s. Obviously, I was not a surgeon, I was a student, obviously. And this was the isometric era. The 2000 was the anatomical reconstruction era, the double bundle era around 2010, and nowadays the rotational stability era. So return to anatomy. And the ACL doesn't work alone. This is really important. This is actually published in 1975, when back these days there is a procedure called 5-in-1. And we were experimenting actually, and we were doing 5 procedures around the knee. Actually, that's what we were trying to do, to stabilize the knee. But back then we didn't know that the primary stabilizer is the ACL. But it's not alone. It has important secondary stabilizers. The posterior horn of the medial meniscus, the ramp lesion, the meniscotibial ligament, the posterior medial capsule, the posterior oblique. Remember, always remember the posterior oblique, and the anterolateral complex as well. So, I would say the knee functions as a rotational ecosystem. Sorry. I think that the publications shift toward the anterolateral part, as I told you before, and we have forgotten the posterior oblique. It's a restraint of internal rotation. We can see here, it wouldn't, okay. We can see here the semimembranosus, and this part is the posterior oblique, a really crucial part which attaches to the rump lesion, and by a sudden contraction, it will create the rump lesion. You see how important this is? It's a frequent concomitant injury with ACL rupture, and is associated with rump lesions, as I told you before. So not every persistent pivot shift comes from the graft. Do not forget that there are normal knees that have slight positive pivot shift. So think. The posterior oblique, a forgotten ligament, was published by the team of Michael Handes, we have here perhaps, and back in 2021, first published in 1973, and the importance and necessity of this ligament was effort upon reviews, and Michael Handes and his team told us that the posterior oblique is a predominant ligamentous structure in posterior medial corner of the knee. It's the posterior 1/3 of the medial collateral ligament, and it resists to valgus pivot shift and in synergy with the semimembranosus. As I told you before, these are the sites of possible tears of the posterior oblique, and this is an image for rump lesion. The current classification is by Grief and Associates in 2020, and it's divided in 5 types: the stable and unstable ruptures. Why do rump lesions matter? With a rump lesion, we have increased anterior tibial translation, so a bigger load to the ACL graft, increased internal rotation, bigger loads, increased forces to the ACL graft. Don't forget, the medial meniscus is actually a really good secondary ACL stabilizer. It's a helper, it's a helping hand. Another helper is the fitting of the curatum of the medial femoral condyle to the medial tibial condyle, the height of the meniscus as well. So think everything from the medial point of view. As the ACL ruptures, the rotational center changes, and this is something really important. It's not a ligament that it's ruptured, it's a whole knee that the rotational center shifts. This is what happens, and we have to restore the shifting of the rotational center of the knee. The knee actually is an ecosystem, as I told you before, of which sequentially some ligaments are torn during the injury. So it's never the same, always individualized. It could be an ACL, but it could be other things as well. It's not only the ACL. Always remember this. It's all the structures I told you before. So the shifting of the center of rotation of the knee, back in 2014, it's published that the center of rotation shifts to the lateral margin of the medial tibial plateau and a little bit in the front. Thus, when posteromedial structures fail, the ACL graft becomes overloaded. The femur and the tibia are no longer around their normal axis, and new cartilage areas are with higher pressure, possible damage as well. So MRI is the key. Through evaluation by us, not our radiologists, we have to look at the MRI, and the MRI inflection may improve sensitivity, posteromedial bone marrow edema to recognize the rump lesion, meniscocapsular separation with fluid, and always check during the arthroscopy, through the Gilquist portal. Always repair to restore knee biomechanics. This is a patient of mine and a posterior medial portal. The lessons from SK consensus, as Dr. Teaser told us before, the tunnel positioning and widening, the meniscal status, think of everything, the ramp lesions, the tibial slope, the graft choice. This is really crucial for me. The ACL revision is no longer a tunnel problem. It's a whole knee problem. It eventually will deteriorate the knee. Look for biology, look for mechanics, look for alignment, look for meniscus status and rotational stabilizers. Why did the operation fail? This is a good question. Not which graft should I use next. Find the cause. So, the ACL injuries are rotational injuries. The ramp lesions are frequently missed. Always have a high suspicion for this. The posterior medial structures matter a lot as well. The posterior oblique. Don't forget this really important ligament. The change of rotation when ACL is ruptured, and always think that we have to restore actually the center of rotation. The successful ACL reconstruction means restoring the whole rotation unit. So something to consider, and this is my point of view. Read and think wisely. We as a community are aiming to the anterolateral repair, tightening, etc., anterolateral modified lemur, etc. But the anterolateral instability and insufficiency is the result of the medial instability, actually. We have videos with super slow motion that prove this. So the cause is the medial insufficiency and the result is the anterolateral instability. So aim for this. Know your biomechanics. This is my point of view, my take-home message. Thank you very much.